Greetings, my name is Caldwell Esselstyn Jr. I direct the Cardiovascular Disease Prevention and Reversal Program at the Cleveland Clinic Wellness Institute. And I'm happy to share with you this morning part 2 of our research and nutritional strategies for halting and reversing coronary artery disease. Right now we're going to talk about the defense mechanisms and the downside of some current cardiovascular disease drugs and therapies. Now, the endothelial cell and DDAH, the endothelial progenitor cells, HDL cholesterol, and gut microbiota are all going to be key in this section. We're first going to start with the endothelial cell. And actually, we sort of thought of the endothelial cell up until 1980 as sort of a cute little red brick that was lining these lovely pipes, these arteries. And that all changed in 1980 because that was when Dr. Furchtgott in Brooklyn actually was doing a research where he took the aorta of the rat, the largest blood vessel in the rat, and he would do this sort of elliptical cut on it right through the endothelial cell, immersed it in saline, and he would find that it would constrict. Then one day, no cut, no injury to the endothelial cell. They immersed it in saline and it dilated. They did it again, it dilated. So now globally, the race was on to try to discover what was this EDRF that Dr. Furchtgott had discovered, endothelial-derived relaxation factor. Thank heavens, that term was with us only 8 years. At the end of 8 years, Dr. Furchtgott, Dr. Luignarl, and Dr. Murad found out that the EDRF was, in actual fact, a gas, nitric oxide. Those 3 men received the Nobel Prize for that discovery in 1998. Now, what does nitric oxide do that makes it so unique and powerful? Nitric oxide, for example, will prevent the intracellular stickiness from forming. That is, when you are eating the cheeseburger, you're eating the hamburger, if you've got plenty of nitric oxide, you're trying to protect yourself from that stickiness. Number 2, nitric oxide is the strongest vasodilator in the body. When you climb stairs, the arteries to your heart dilate. The arteries to your legs dilate. That's nitric oxide. Number 3, nitric oxide prevents the formation of inflammation, thickening, and stiffness in the wall of our artery. It protects us from getting hypertension, high blood pressure. Number 4, nitric oxide in plentiful amounts will prevent us from ever developing blockages or plaque. Number 5, nitric oxide will prevent the migration of smooth muscle from the artery wall from migrating into the plaque. Number 6, nitric oxide will prevent and destroy the foam cell, the Darth Vader of this whole sequence. Now, the next great thing that really happened was what happened when Robert Vogel took a group of healthy young subjects to a certain fast food restaurant. Now, I should mention that to measure measure nitric oxide, we use what we call the brachial artery tourniquet test. For those of you who aren't familiar with this, you simply take an ultrasound probe, place it over the brachial artery at your elbow, and then for 5 minutes you will encircle the upper arm with a blood pressure cuff that you inflate above systolic blood pressure. That for 5 minutes you have 0 blood flow to the hand and the forearm. Now, I've had that done. It's not exactly habit-forming. But then you release the cuff and you remeasure, once again, now, the new diameter of the brachial artery after you've released the cuff. In the normal individual with plentiful amounts of nitric oxide, it'll now be 30% more dilated than it was at baseline. So now Vogel took this group of healthy young subjects to this fast food restaurant divided them in half. Then the half who had their cornflakes had their brachial artery tourniquet test taken, dilated, normal. The other half, who had the hash browns and sausage, within 120 minutes, they were unable, with the brachial artery tourniquet test, they were unable to dilate the artery. That single meal of hash browns and sausage had so compromised, it had so trashed the capacity of their endothelial cell to make nitric oxide. They couldn't dilate the artery. Now, being young, as the day went on, late in the afternoon, early evening, they could begin to recover. But you and I know that the next morning for breakfast, it's going to be scrambled eggs and bacon. At lunchtime, we'll have white bread with cold cuts and mayonnaise. And maybe for supper, baked potato with sour cream, lamb chops, vegetables soaked in butter, ranch dressing on a salad, and ice cream for dessert. Here in the good old USA, boy, we just take those endothelial cells and we just pound them and we injure them. And is it any surprise that by the time we're graduating from high school, we have the foundation for coronary artery heart disease? Now here's a graph that simply shows now the relationship on the left where we have flow-mediated dilatation, and on the right, obviously, on the line, we have different types of diet. So the worst diet for vasodilatation is the Atkins diet. The next worst is South Beach, and then the champ, of course, is plant-based. Now, here we have what may be a little bit complicated. Let's simplify this by dividing it sort of in half. If we go to the left, we'll see that we see arginine, nitric oxide, synthase, and nitric oxide. Those three steps, think of it as the raw material, nitric oxide synthase, the factory, nitric oxide, the end product. Now, arginine is a semi-essential amino acid, and it's going to be there in your food. You are not deficient in arginine, because what happened when people first began to understand this sequence, they said, listen, I'm going to go down to the health food store, I'm going to buy a jug of arginine, and I'm going to have nitric oxide blowing out of my ears. Don't do that. That was tried in 2006 in an interesting study in the Journal of the American Medical Association. They took men who had recently had a heart attack, half with the controls, the other half taking supplemental arginine. They prematurely stopped the study at 6 months because no new heart attacks in the control group, 6 new heart attacks in those who were taking the supplemental arginine. You're going to get all the arginine you need from your food. But now let's go shift our attention to the right, to the ADMA, and there's an arrow of ADMA up to nitric oxide synthase. In other words, we don't want too much ADMA, asymmetric dimethyl arginine, which is a natural product of protein metabolism, because too much ADMA is going to muck up the ability that we have to make nitric oxide. So the body gets rid of it in 2 ways. 1, through the urine, and 2, it is metabolized away by the enzyme, DDAH, a powerful but delicate enzyme. Now, if we look at people who have renal failure, let's say they're on dialysis, we know that they have a much higher rate of stroke and heart disease. Why? Because they cannot really get rid of their ADMA, and that obviously compromises their ability to make nitric oxide. But what about the rest of us who have normal urinary output, normal kidney function? Is there anything that we do that injures our DDAH, our dimethylarginine dimethylaminohydrolase? Yes. High cholesterol will injure DDAH. High homocysteine will injure DDAH. High triglycerides will injure DDAH. Insulin resistance will injure DDAH. And diabetes will injure DDAH, as will smoking. Now, of all the things that we've just discussed, every one of those is going to be optimized by a plant-based diet, with the exception of smoking. So it's pretty exciting and pretty powerful to think you don't have to take drugs with these terrible side effects to get these optimal benefits. Now, this is interesting because this is a murine, a mouse study from Harvard, looking at mice who have a tendency to make atherosclerosis. Now, at the top, you're going to see what happens after 12 weeks with a mouse that is on lab chow. No problem. In the middle drawing, you see one who's eating the typical Western diet, and the bottom one is eating the typical Western diet with an increase in the amount of protein. Now, it's important to point out that between the middle drawing and the bottom one, there is absolutely no difference in calories. It's just that there is a greater percentage of protein in the bottom. Now, throughout that experiment of 12 weeks, the cholesterol levels in the middle and the bottom were the same. The amount of bad LDL cholesterol in the middle and the bottom were the same. The only difference was the macronutrient excess of protein. Now, it took me a while and several phone calls to Harvard to find out what was the protein that they were using. And the protein was casein, the major protein in all dairy. Very profound difference in how that seemed to accelerate the disease in this setting. Now, here is another one of these wonderful protective mechanisms, and these are the endothelial cells, the endothelial progenitor cells, rather. The endothelial progenitor cells comes from our bone marrow, and it replaces our senescent, injured, worn-out endothelial cells. And if I have somebody in front of me who happens to be obese, somebody who is hypertensive, somebody who is diabetic, somebody who is a smoker, somebody who is a couch potato, if I measure their endothelial progenitor cells, they're going to be low. On the other hand, if I take somebody who's just the reverse of that, who is slender, not diabetic, not a smoker, not hypertensive, physically active, they're going to be higher. But for my patients, I'm greedy. I really want to see those endothelial progenitor cells sparkle. How do I do that? We learned that from the study of the healthiest human being on the planet, an Okinawan woman between the ages of 17 and 34. Half of that group were the control. The other half were consuming 5 additional green leafy Okinawan vegetables daily. At the end of the study, when they measured the blood levels of endothelial progenitor cells, they were strikingly higher in those women who were consuming the additional 5 green leafy vegetables daily. And I think when we come to the treatment section, you'll see how important this can be. Now, the HDL cholesterol. For years, we were taught that it was a high HDL that was going to protect us from coronary artery disease. But recently, that's had a serious relook. And I share with you today the study from Dan Rader and his team from the University of Pennsylvania, which was reported in the New England Journal of Medicine on the January 13th, 2011. They took 2,000 participants and they drew blood and measured the HDL cholesterol level. They had some that were high, some that were medium, some that were low. Then they did a fascinating thing. They then measured the capacity of each of those HDL molecules to do what we call reverse cholesterol transport, the job of HDL cholesterol. And guess what? There is absolutely no relationship whatsoever between the measured blood level of HDL cholesterol and its capacity to do its job. And it was interestingly enough, the very next month, out of UCLA, came this study that shed a great deal of light on that, because they found that by looking at and measuring the ability of the moiety of our HDL cholesterol, which is its major protein, ApoA1, that if you are eating the typical Western diet, what happens is you will injure that major protein of the HDL cholesterol. And once you have injured that major protein of the HDL cholesterol, even if it's high or whatever, you have now changed that HDL molecule from an anti-inflammatory molecule trying to protect your health to a pro-inflammatory molecule joining with your LDL to injure you. Rather interesting, very exciting, and again, quite exciting to think that plant-based nutrition can prevent that oxidation. Now, what about the microbiome? This may look a little complicated, but all I really care about here is this graph in the upper left. When we talk about the microbiome, we're talking about the bacteria in our gut. And I think probably for most of the history of medicine up until within the last 10 years, we just sort of ignored these absolutely trillions of bacteria that are in our intestine. But suddenly, in the last 10 years, if you look at that graph in the upper left, you'll see how there were very few studies on it up until around 2007, 2008, and suddenly these studies began to absolutely take off because we've learned some interesting things about the microbiome and how these bacteria relate to our health. There are, for instance, right now there are many more microbial genes that have an astonishing complexity than there are human genes. And the association between humans and microorganisms are evolutionary and they're very old. And the microorganisms are adapted to each other, and microbes affect many physiologic functions of humans, from depression to obesity to heart disease and to cancer. Now here's some interesting research that emanated right from the Cleveland Clinic. This was Stan Hazen and his group in the Department of Molecular Biology. And they took a look at persons who were omnivores. And when omnivores consume the lecithin and carnitine that are found in these animal products that you see listed here, what their bacterial flora produce is a molecule called trimethylamine, TMA. And trimethylamine is very rapidly oxidized by our liver to trimethylamine oxide, which is capable of producing vascular disease. Now, here you can see the configuration of how this happens. You consume these high-fat animal products. You produce, through your gut bacteria, trimethylamine. It's oxidized in the liver to trimethylamine oxide, which can produce vascular disease. But the exciting thing about this that was also learned was that if you, for instance, would give somebody who is totally plant-based in their nutrition, you give them a lamb chop, they don't make trimethylamine oxide, for example. On this slide, we're looking at a labeling of carnitine when it is given with that graft on the left in food, and you can see immediately the line going up for those who are omnivores, and at the bottom, at the baseline, this low level of vegans who can't make TMAO. On the next graph to the right, in the middle, we see what happens if you take just even a labeled amount of carnitine and give it by mouth, not as a tenderloin. And immediately again, you can see how the omnivore makes trimethylamine oxide, but again, those who are plant-based or vegan do not. On the other hand, if we look at the urine, those two final graphs on the right, on the upper one, when you look at the urine in somebody who's fed the steak or the lamb chop, the red is how high the urine is in persons who are omnivores, and you can see on the right the small amount with someone who is vegan. On the other hand, when you this time, you don't give them the steak on the bottom, but you give them the labeled pure TMAO. There it is. You can see again, the elevation in red of the urine TMAO in the omnivore, very little in the vegan. Pretty powerful stuff, because what this is doing is it's showing how this is a validation of the approach of plant-based nutrition to deal with coronary artery heart disease. Moderation kills. Interestingly enough, this is a chapter title in my book. And for instance, if we now understand what are the range of foods that every time they pass your lips, you are going to injure your endothelial cells, why would I, with a patient with heart disease, ever want them to have further injury to their endothelial cells, which have already been so trashed that they've been able to establish a foundation of heart disease? And I think we'll see that again when we come to treatment, how powerful and important it can be, because the persons who are totally compliant really are those that always appear to do the very best. Now we have to take a little bit of a look at many of these medications that are used in heart disease today. There's no question that they can be helpful from the standpoint of symptoms, but the tragedy is that very few of them have anything to do with the causation of the illness. Now, the statin drugs came along in the late 80s and early 90s, and there's no question that the statin drugs in somebody who has heart disease can be very beneficial, but today really it is still very challenging to see any kind of significant benefit in giving statin drugs to those who don't have disease. And it's interesting that there just seems to be enough of a sense of concern that patients, usually after several years, especially seniors, find that they're going to stop taking these statin drugs. What about the ACE inhibitors and the angiotensin receptor blockers? Well, if somebody is on those and they happen to get a contrast study, the amount of nephropathy or injury to the kidneys is increased. Great deal of discussion about fish oils. In the early 90s, there were some small studies that suggested there was benefit, but as we've come to know these agents more intimately, here we have, for instance, a study of 20,000 patients, and fish oil does not prevent or help heart disease, so you can save yourself from money from that standpoint. Now, what about aspirin? There's no question that with patients with heart disease who are still eating the Western diet, they're at risk for clotting, and aspirin will help to reduce that likelihood, but aspirin does have a side effect. For instance, aspirin can be responsible for a major cerebral bleed, which is tragic, or a gastrointestinal bleed. And it also has been shown in a small but significant percent to contribute to macular degeneration. So even with benign appearing drugs, we have to be very careful in how we utilize them. It's also found that niacin, when it's given in patients with a low HDL, with the cholesterol levels that are acceptable when receiving statins, really adds nothing in a way of additional benefit. Now, what about beta blockers? Beta blockers, when they're carefully studied, appear to have no additional benefit in those who've had a prior myocardial infarction, no additional benefit in those with known coronary artery disease without a prior myocardial infarction, and of really questionable risk in those with coronary artery disease risk factors only. And the author of this study went on to say that without congestive heart failure, the evidence for prevention of long-term clinical outcomes is non-existent. Now, we have to examine, again, these procedures that we use, such as stents and bypass. Now, there's no question that if I'm in the middle of a heart attack, the person that I want next to me is a man or a woman who has great expertise in stents. Not only are they going to save my life, but they're going to save a lot of my heart muscle from further damage. All right, that takes care of 10 or 12% of these patients, but what about the other the other 88% that may be getting these procedures electively? When they're carefully studied, elective stents do not prolong life, and elective stents do not protect from a future heart attack. Is there side effects with stents? Sure. The worst is, of course, death. Not very common, maybe 1%. But let's suppose that we do 1.2 million. That means that 12,000 people are going to lose their life with a stent. How many will get a heart attack getting a stent? 4%. 4% of 1.2 million is 48,000. Now, if we look at bypass surgery, the mortality is a little high, but we don't do as many. 500,000, 3% mortality, that's 15,000 deaths with bypass. How many strokes with bypass? The same, 3%. That's 15,000 strokes. Now, take it over a 10-year period. That's 270,000. Almost 250,000 people will die getting these procedures. At the same time, there will be 480,000, almost 500,000 heart attacks. And how many strokes? 150,000. That is serious morbidity and mortality. Now, what about expense? We know right now that at the present time, this country is being pulled into debtor's prison faster than anything you can imagine by the entitlements. That would be Social Security, Medicaid, Medicare. What is 40%, what is 35% of Medicare? No, it's 45%. My experience. 45% of Medicare is cardiology. And what is cardiology today? It's the symptomatic treatment of this disease. You have your first stent, you'll have your second stent, you'll have your third, fourth, or fifth stent. Then you'll need a bypass. Then you'll need more stents to keep the bypass open. And then finally you get congestive heart failure and you die. And you die of a completely benign foodborne illness that never has its cause treated. I think we can do better. Now, when we do bypass, we do these really rather fancy vein grafts, but the veins come from our leg, and the vein was really never intended to be in an arterial system. So Duke University looked at 4,290 vein grafts to see what their survival was at 12 and 18 months in terms of their patency. If the vein was harvested endoscopically, the failure rate was 46.7% at 12 to 18 months. On the other hand, it was improved, it was better. If you did an open harvesting, 38% failed at 12 to 18 months. So it really is not a long-term solution, certainly to this problem, and it has certainly a high amount of mortality and morbidity. So if we now simply compare standard medical therapy, now I'm not talking about intensive lifestyle change or nutritional modification, but we're talking about just intensive medical therapy compared to intensive medical therapy and stents. At the result, with these 61 studies, 25,000 patients, no fewer deaths or heart attacks. So that again would suggest that elective stents can be spared. Now, this is just for a quick little review here of when we do bypass surgery, where does it go? Well, the veins are usually sewn into the aorta, which is a ready source of blood. And here we see on the right, the vein graft going to the circumflex. In the middle, the vein graft is going to the left anterior descending. And on our left, the vein graft is going to the right coronary artery. This next one happens to be the internal mammary artery inside the chest wall, which is carefully dissected out. And this really has an excellent track record and can last for upwards of 15 or 20 years. This happens to be a demonstration of a stent. And the stent, as you know, if a balloon goes in and blows up, fractures the artery and pushes the plaque content off to the periphery, then it's withdrawn and the stent is put on the catheter, and then the stent is blown up to brace open and hold the artery open. You can see that the artist here has drawn in some small thrombi that were dislodged. They can go downstream actually and cause a small heart attack. But once the balloon is withdrawn, your blood will not run over this bare wire without clotting. So therefore, these patients will have to take upwards of a year or more an clotting drug. And that puts them somewhat at greater risk, certainly for a hemorrhagic event. Now this is just, so I think, very interesting from a historical standpoint. This is Dr. Mason Soanes, who was the man who discovered coronary angiography. And that's his good friend and my friend, that was Rene Favaloro, the father of bypass surgery. It was interesting how this all kind of came about, because in 1958, Mason Soanes was the director of the Cleveland Clinic Cardiovascular Catheterization Laboratory. And one day, when they were doing a catheterization of the ventricle, you have to know that up until 1958, it was felt that it was absolutely verboten ever to catheterize a coronary artery, because it was felt that it would be absolutely fatal. And so they were doing catheterizations, measuring heart valves and ventricular chambers. And Dr. Soanes was looking at the image amplifier while his associate was threading the catheter up. And when it came time to empty the syringe, Dr. Soanes immediately noticed that the catheter was not in the ventricular cavity, but the coronary artery was receiving this entire bolus. And he looked at the patient's EKG, and it began to flatline. He yelled at the patient, "Cough!" The patient coughed, and suddenly the EKG was restored. But Soanes had a magical moment, saying to himself, "I think we can do this. I think we can dilute the dye." They certainly don't have to get the quantity of dye that we injected in this patient. And they worked and tinkered with this and were able to work out the wrinkles, and suddenly coronary artery catheterization was born. But that was 1958. What could they do with it? They just mapped out these horribly diseased arteries for the next 9 years. And along comes this other fellow, Favaloro. It was interesting that when I was taking my general surgery rotation through cardiothoracic surgery, that Dr. Favaloro was, at that time, a resident who had just come to the Cleveland Clinic from Argentina, where he had been a general surgeon for 10 years, and he wanted to study under Don Effler and learn cardiothoracic surgery. He was such a delightful individual, so skillful, with really wonderful interpersonal skills, that he joined the staff of the Cleveland Clinic. And in 1967, actually when I was in Vietnam, he was operating on a patient where he had seen the coronary angiography earlier, and suddenly the heart began to go blue. He yelled at his team to prep the leg. They immediately prepped the leg, made an incision, harvested the vein, and placed a coronary bypass graft, and thus coronary artery bypass surgery was born. Favaloro was very industrious with this, and he wrote article after article and the monograph on this. He was recognized throughout the world as the father of coronary bypass surgery. And Rene, not only could he speak Spanish, but he could speak English, he could speak Italian and French, and it was practically any place in the world where he went, he could find somehow a common language, which was very flattering to the host country. So it was with great joy that I share my knowledge of these two men, both of whom were my friends. And sadly today they are in the big meadow in the sky. But I'm sure very excited about the progress that we're seeing in this disease. Now, this is the president, chairman of cardiology at the Cleveland Clinic, who says that multiple studies show that if you have one ruptured plaque, you have many. In other words, as these plaques rupture, I showed you the sequence earlier of how you can have a heart disease. But sometimes the body is able to dislodge the clot that tries to form, and you see sort of the graveyard of where that ruptured plaque had occurred. Now, Dr. Nissen's predecessor, Dr. Tobel, said at the Cleveland Clinic there is a much more liberal use of angioplasty and stenting than there needs to be. And Doug Morrison, in the Journal of the American College of Cardiology in 2010 said the following. And this, I think, was really pretty profound when we think about what we're saying today. Nothing, nothing, nothing. Not statins, not angiotensin receptor blockers, not beta blockers, and most assuredly, neither bare metal stents or drug-eluting stents nor bypass grafts constitutes either a cure for coronary artery disease nor is risk-free. Now we give you a little break. This is the dairy industry that's a little bit out of control. This is the one from France. Now, how would you like to be this gentleman asking for insurance? And sadly, this is the way today with patients with coronary disease. The cause of the disease is not being treated, which is why the disease in these people usually progresses as they move through life. This is actually a comment by Walter Willett, who is the chairman of public health at Harvard. Walter Willett says the current path leads to increasing adiposity, diabetes mellitus, cardiovascular disease, and disability, and an unfit, socially isolated population stuffed with pills and subjected to frequent palliative procedures. And here is a study from the American Heart Association journal Circulation, 2011. Between 2010 and 2030, the real total direct medical costs of cardiovascular disease are projected to triple from $273 billion to 818 billion. Now this is interesting. This I happened to get the Harvard Heart Letter, and on the back of the Harvard Heart Letter, the subscribers have an opportunity to ask questions of the editor. Now this particular gentleman was 75 years of age. At age 65, he had had a triple coronary artery bypass, and he was asking the question to the editor: why was it when I've done everything correctly, I'm told now at 75, I need another triple bypass operation? Well, when I read this, I was really quite curious, because the editor had replied, you should congratulate yourself. The best that can be hoped for in this disease is to slow the rate of progression. So I wrote to the Harvard Heart Letter and I said, I respectfully disagree, and I shared with them some of our research. And I got a letter back saying that, Dr. Esselstyn, I would agree with you that this is one of the most complex of diseases. Well, anyway, that was an interesting exchange back in 2001. And I'm going to share with you shortly, I think, how we can perhaps improve our results with coronary disease. For instance, for today, when you see a doctor, if you have heart disease, you may no longer be pouring gallons of gasoline on the fire, but sadly you may still be pouring quarts of gasoline on the fire. The fire doesn't go out. If we're going to be asked to treat you, we're not going to allow you to have a single thimbleful of gasoline on the fire. We have to have the fire go out. Now here we have 2010. This is Newsweek saying desperately seeking cures. Well, I think that hopefully today we're going to try to show you that we really don't have multiple common chronic killing diseases. We have one disease which has multiple manifestations. Now, this happened to be some quotes from the New York Times at the time that President Clinton had his second go-around with heart disease, and he had to have some stents. And this was what his surgeon said: this is not a result of his lifestyle or diet. This is a chronic condition for which we don't have a cure. And on the other hand, the president of the American the president of the American Heart Association at that time, Clyde Yancey, said this kind of disease is progressive. There aren't any cures. Gentlemen, with all due respect, I totally disagree. Now this is a picture of Bill Sheldon. In 1985, Bill Sheldon was the chairman of the Cleveland Clinic Department of Cardiology. It was in the summer of 1985 that I went to Bill and I asked if I could speak to the department because I had a proposal for a research study on plant-based nutrition in patients who were seriously ill with coronary artery disease to see if we couldn't halt or maybe even possibly reverse their disease. Now, we're going to discuss that study in the next section, part 3.